Hello, everyone. My name is Crystal Pfizer, and I'm going to be discussing electronic health records and patient portals. Historically, the Hippocratic ethic has been viewed as a paternalistic model where physicians acted in their patients' best interest and, in turn, patients deferred to their judgment. This all started to change as access to the internet became more prevalent. Patients are starting to become more informed decision makers and taking a more active role in the management of their health care. Electronic health records and patient portals are paving the way to change the dynamic in the traditional provider-patient relationship. In order to discuss electronic health records and patient portals in an effective manner, we're first going to define them. For the purposes of this presentation, an EHR is a digital version of a patient's paper chart. EHRs are real-time, patient-centered records that make information available instantly and securely to authorized users. An EHR system is designed to go beyond standard clinical data collected in a provider's office and can be inclusive of a broader view of a patient's care. They contain patient's medical history, diagnoses, medications, treatment plans, etc. But the primary purpose of an EHR is to make healthcare management easier for professionals. To that end, they allow access to evidence-based tools that providers can use to make decisions about a patient's care. They automate and streamline provider workflow. They use computerized physician order entry, which allows providers to enter orders for drugs, lab tests, and other procedures electronically. They also use health information exchange, which is the process of sharing patient information between different organizations. Organizations like specialists, medical imaging facilities, emergency facilities. The ultimate goal being that everyone involved in a patient's care has the information they need when they need it. A patient portal is a provider-based, secure online website that gives patients convenient 24-hour access to personal health information from anywhere with an internet connection. Some are really basic in that they just provide access to the EHR, secure email communication, prescription refill capabilities, and targeted educational material. But the overall goal of portals is to empower patients and change their role from a patronized patient to an informed patient and further to a responsible, autonomous, and competent partner in his or her own care. And so consequently, some portals are incredibly robust. They allow you to make payments, revise and correct information, view radiology images like x-rays and CT scans. Some even allow you to upload self-reported data like blood sugar levels. On the whole, healthcare records have come a long way since they were first digitized in the late 60s. In fact, the history of EHRs in the United States can be traced back to the 1960s and 70s when parallel efforts in academic medical centers and government clinical care organizations sprang up around the country. Notable developments in the private sector include the Health Evaluation Through Logical Processing System, HELP, by the University of Utah and the 3M Corporation, the EHR developed by Lockheed, which eventually became Allscripts, and the computer-stored ambulatory record, CoStar, by Harvard and Massachusetts General Hospital. Then the federal government joined the fray with the launch of the Decentralized Hospital Computer Program, which was used nationwide with the Department of Veteran Affairs. Later, they developed a composite healthcare system, which was used worldwide to serve as the Department of Defense's clinical patient record system. In the mid-2000s, it came to light that the United States trailed embarrassingly far behind other industrialized nations with regard to EHR use. To address this problem, President George W. Bush introduced, during his 2004 State of the Union address, an initiative to make EHRs available to the majority of Americans by 2014. The Bush administration established the Office of the National Coordinator for Health Information Technology, or ONC. The ONC then contracted the Certification Commission for Healthcare Information Technology to develop EHR certification criteria. In 2009, President Obama launched an unprecedented effort to adopt EHRs nationwide by passing the Health Information Technology for Economic and Clinical Health Act. HITECH, as it is known, is a multi-billion-dollar effort to transform healthcare delivery through widespread use of EHR technology. Almost $30 billion was set aside for the ONC and the Centers for Medicare and Medicaid Services. The CMS proceeded to create a large-scale incentive program to encourage millions of healthcare providers and thousands of healthcare institutions to adopt certified EHRs and to demonstrate meaningful use for improving patient care. The CMS Meaningful Use Incentive Program is the driving force behind the rapid development of EHR and patient portal technology. Meaningful use refers to using certified EHRs to improve quality, safety, efficiency, and reduce health disparities, engage patients and family, improve care coordination, and maintain privacy and security of patient health information. The program is designed to reward early adopters and penalize late adopters. Those who adopted in 2011 or 2012 received the maximum incentives. No incentives will be paid to those who adopt after 2014, and eligible providers who choose not to adopt certified EHRs will see a reduction in Medicare payments starting in 2015. The incentive program sets specific objectives in 3 stages that eligible professionals and hospitals must achieve to receive payments. Stage 1 of the program began in 2011 and sets the basic functionalities for EHRs. The requirements are focused on providers capturing data electronically and sharing it with both the patient and other healthcare professionals. Eligible professionals and hospitals must meet a set core of objectives and a defined number of objectives to be chosen from a list. Stage 2 began in 2014 and uses advanced clinical processes. The requirements are focused on health information exchange between providers and promoting patient engagement by giving patients secure online access to their health information. As with Stage 1, there are core objectives and a list of optional objectives to choose from. Stage 3 will begin in 2016 and will focus on improving health outcomes, but the objectives have not yet been finalized. Former president of the American Medical Informatics Association, Charles Safran, once said that these are promising times for the widespread application of information technology to improve the quality of healthcare while also reducing costs. Right now, the patient is the most underutilized resource in healthcare. Addressing this issue, the CMS incentive program demands patient engagement. And in order to meet those demands, hospitals and other providers are turning to patient portals as a means to engage patients. Portals represent an opportunity for gains for both the patient and provider, and many studies have been done to measure their effectiveness. An analysis of 32 separate studies indicated that patient portals could lead to improvements in clinical outcomes, patient adherence, patient-provider communication, patient empowerment, and patient satisfaction with health services. 15 of 18 randomized control trials demonstrated significant positive changes in these outcomes, and the majority of observational and qualitative studies provided indications consistent with these outcomes. No studies found adverse consequences to patient portal implementations. One of the early theories was that patient portals lower health resource consumption through a substitution of services. According to the analysis, this was not only unsubstantiated, but of the 8 studies that addressed healthcare utilization, 5 concluded that higher health resource consumption occurred after implementation, and 2 found no change. This suggests that portals actually complement traditional modes of provider-patient communication as opposed to substituting for them. Because patients with chronic diseases like diabetes have to continuously monitor their health, the theory is that patient portals may provide a unique opportunity for self-management. In 2008, a qualitative study was done to determine the interest in using a patient portal for patients with diabetes. The study found that interest in patient portals inversely corresponded to satisfaction with the existing provider-patient relationship. In other words, the more satisfied a patient was with a traditional provider-patient relationship, the least likely he or she would choose to use the patient portal. Focus groups revealed that in situations where the doctors did not provide adequate information about nutrition, or lab results were hard to get, or doctors were difficult to get a hold of, the patients were likely to use the patient portal. The reverse is also true. One gentleman stated that he has lab work done the first Monday of every month, and his doctor personally calls him that same day to let him know the results. Another man said that he emails his sugar levels to his doctor every 6 weeks, and she responds immediately with whether or not he's on the right track. In cases like these, patients are not likely to see the benefit of using a portal. Overall, this study raised interesting questions about the quality of care in healthcare institutions. As patient portals become more commonplace, will providers become lax in their duties now that patients can get so much information through their portal? This provides an avenue for more study, as there is very little research regarding the quality of care from the provider before and after implementation of a patient portal. There are also indications that people with low computer self-efficacy or who don't trust new technologies will not likely use a portal. In a focus group, one woman stated that regular email communication would displace the person-to-person contact the healthcare system is built on. Another study indicated that the design of the portal itself is influential in whether or not a person will use it. Patient-centered design would improve patient understanding and could lead to better health outcomes. This is corroborated by other reports of people unwilling to take the time to learn a complex system when they could just pick up the phone and call their doctor. There is also some limited research on how EHR implementation is affecting providers. In 2011, 76% of physicians with EHRs had systems that are certified to meet the meaningful use criteria. This most likely includes a tie-in with a patient portal because meaningful use includes sharing health information with the patient and secure email communication with patients. Physicians with a certified EHR were more likely to report time savings compared with physicians that use an EHR that does not meet meaningful use criteria, but only in some areas. For example, they report that electronic prescribing saves time and that they receive laboratory results faster with a certified EHR. However, physicians also reported that it increases the time taken to answer pharmacy calls. Over 3/4 of physicians that use any type of EHR report that the amount of time taken to plan, review, order, and document care has increased due to using the system. These findings suggest that the quality of the EHR can determine the effectiveness and efficiency of provider care. The security of protected health information has recently become a prevalent issue because of the CMS incentive program's Stage 2 requirements. Stage 1 called for physicians and hospitals to provide patients an electronic copy of their health information. Stage 2 requires that physicians provide patients with the means to view online, download, and transmit their health information. Security of the protected health information is important not just for meeting the HIPAA requirements and high-tech requirements, but also for installing a sense of trustworthiness in patients. Many large hospital systems develop their own EHR and patient portal systems. Consequently, they must assume responsibility for building in privacy and security controls. Key features a portal should have for basic security include user authentication, meaning the portal should require a minimum standard for passwords, but they shouldn't be so complex that it deters patients. The system should also have role-based authorization and single sign-on capabilities. For example, parents of a young child who serve as a proxy until the child is of age may be authorized to view different kinds of information than the primary caregiver of an ailing family member. Secure transport. A portal that allows users to download information must provide secure, encrypted connection between the patient and the portal. Options include a VPN or a gateway. Auditing and integrity control. If portals allow patients to upload or alter data, there must be a mechanism to track and ensure the integrity of those changes. An audit trail to track what each provider has viewed and altered is also paramount. Although HIPAA only requires that reasonable care be taken to protect protected health information, hospitals should put a security program in place to ensure their program meets the highest standards. A comprehensive security program should include a solid understanding of the organization's data security risks. The program should include regular comprehensive security assessments and an incident response plan in case of a breach. Office-based providers and small to mid-sized medical centers usually choose commercial EHR and patient portal software. As EHR vendors typically include portal technology as part of their system, this option is very convenient. In these cases, the third-party vendors are responsible for the fundamentals of security. However, even when depending on a vendor for the security basics, hospitals and other providers should always conduct periodic security assessments because the threat landscape is constantly changing. This is a really exciting time to be in health information technology, as everything is changing and evolving at a rapid pace due to recent legislative changes. EHRs and patient portals have changed the very nature of the patient-provider relationship. Patients are now informed and taking a more active role in the management of their health care. Studies show promising results with patient satisfaction and empowerment. Physicians and other providers are also reporting positive changes as a result of using certified EHRs. Now that protected health information is entirely digital, security concerns are paramount in everyone's mind. New regulations on how protected health information is to be used online means that extra care must be taken to ensure that it stays protected. In terms of research, there's still much to be done. There is opportunity for research regarding the quality of healthcare after implementation of a patient portal, for example. More specifically, patient satisfaction with a traditional patient-provider relationship once engaged with the patient portal. In addition, there is little research on how patient portal use relates to health outcomes. With Stage 3 of the CMS incentive program focusing on health outcomes, I anticipate a great many studies will be done as providers begin to measure the portal's effectiveness. Thank you for your time.